Welcome to Uptown Doula, a podcast that keeps busy parents like you from freaking the fuck out. I'm your host, Haley Jasmine. We are back with part 2 of the podcast. Chris is still with us, and there was just so much to cover around this topic that we decided to break this content surrounding C-sections into 2 parts. Part 1 was all about emergency C-sections, epidurals, and spinal blocks. And if you've not listened, I would highly suggest you go back and do listen. Chris leaves nothing out, and today he is covering everything you need to know about scheduled C-sections. It happens, right? But that doesn't mean your birth experience can't be an amazing experience. If you are planning your surgical birth or know someone who is planning a surgical birth, please tune in and share the podcast. It's not scary, I promise, and Chris and I are by your side the entire time. Our goal of this podcast is to help guide you through the process, give you tools to ease your fears so you're left feeling empowered, because by the end of this episode, you'll have more knowledge than when you started, and knowledge is power. Enjoy the show. Welcome back for part 2. Part 2, we are going over what to expect with scheduled C-sections, and we weren't planning on including this section, but I recently had a scheduled C-section birth like this past week, and I was like, hey, there's a lot that goes into this that needs to be talked about, because there's some instances where women have scheduled C-sections when they may have had a birth plan for a natural birth, and the doc says, hey, for whatever reason, whether it's a breech birth or there's something medically going on, we need to schedule the C-section. It's a completely different process, completely different feel. Yeah. And, you know, my client literally just had this happen, and she was super, super nervous. And what's so great about having you as my brother is that you were in my back pocket. So I appreciate it, because Chris, you actually told me, like, hey, if she wants to talk to me, I'm available. I'm like, heck yeah, she wants to talk to you. And I literally, when I saw her hang up the phone with you, I saw her shoulders drop. And the next thing out of her mouth was, I'm excited.
Good. Very good.
I'm nervous. Talk to Chris. I'm excited. So basically, we're going to go over that conversation that you had with her. And you just mapped out the process. Yep. I was able to give her a lot of the information, but you were able to dive deep into the details of it. And let's just go. Let's get into this. So walk us through a day of a scheduled C-section.
And before diving into the details, this is stuff you're going to get from your anesthesia provider the day of. But if you've heard it before or parts of it before, then you can easily feel a little more prepared to go into it. You can nuance your questions a little more. And whatever the anesthesia provider shares with you the day of all of this excitement, I think it'll stick a little better. So go. Okay. The first part of it is really going over, again, a medical history to make sure we're clear about any sort of additional risk factors that may be there for a spinal anesthetic, because that is the Cadillac for a planned C-section. The spinal anesthetic is very predictable. It's very well exercised. I don't know when they first started doing that for C-sections, but it's been a very long time. And yeah, it's the Cadillac, and essentially it's a single shot in the back that gets you numb, up to your chest for 2 hours. And with that, most C-sections only last about an hour. So, so there's a combing through medical history, making sure the lab values are appropriate, making sure there are no contraindications of any kind for a spinal anesthetic. That conversation happens before going back to the operating room, typically, and maybe in a triage area or a hospital room. And the process is well discussed at that point. The process itself looks like walking back to the operating room or maybe riding in a wheelchair back there. It's kind of rare that a scheduled C-section kind of goes back to the operating room on a stretcher or on a bed. You walk into the operating room, and as some of you know, it's like a spaceship. It's cold, it's sterile, there's very little color except for the blue sterile in the drapes. It's not a very warm, welcoming. It's bright.
It's so bright, but I mean, you don't want dim, fancy lighting.
Right.
You need to see what he's doing.
Seeing what they're doing is really helpful. So
no one looks good in that light.
No one looks good in that light. It's true. Every wrinkle is more pronounced, but
My client got to actually walk, like physically
Right.
walk to the operating room, which was
Right.
cool because
And I think walking helps you take deeper breaths. It helps you zen out just a little bit. And all that anxiety, has a way to move if you're walking. So I think that's pretty helpful. I do recommend taking some music with you at that point. If they allow cell phones in the operating room, have your Zen mix loaded. And I play this Native American flute thing for people who
and
don't.
I'll link it in the comments.
Cool. Yeah. Now,
Or
a lot of
the
people don't like it.
podcast.
I play that music in central Austin and people love it because it's a little bit out there and they're like, oh, this feels like a spa. But if I play it, if I play it out in the country, they get a little offended. They're like, play me some George Strait, this nonsense, this hippie stuff. And it's hilarious to see what's comforting to people.
Or gospel, if
yeah,
you're
exactly.
into gospel
If you have
music.
a gospel mix that matters to you,
A little Jack
definitely bring it.
Johnson, a little Mumford and Sons.
Whatever you want.
Whatever tickles your
Mozart,
fancy.
for sure. So anyway, you go into the operating room. It looks like a spaceship, super bright lights. Everything is sterile. It's cold. You have a seat at on the side of the operating room bed, and you kind of get nestled in. Vital signs will start, specifically blood pressure and pulse oximetry. Maybe the EKG leads, but often it's okay to postpone that a little bit if there's no overt cardiac history. And the anesthesia provider will kind of come behind you, and similar to the epidural, you'll feel that person's likely cold hands along your iliac crest, identifying the same landmarks for an epidural, cleaning it with a cold sterile solution, gloving up, creating a sterile field, and then here comes the bee sting, and that's the numbing injection to kind of make the rest of the process more tolerable. But it really does feel like a bee sting. I told someone that it was going to feel like a pinch. I learned very quickly to try not to use that language because it wasn't a pinch. She writhed and gave me a lot of feedback. She's like, "No, that's a bee sting."
Little colorful metaphors. sprinkled in.
Exactly. Yeah. Very professional. Of
Now,
course.
is the partner in the operating room
No,
at this point?
no.
So it's the same deal.
Same deal. Because if that spinal doesn't set up, then we have a decision to make. Put mom to sleep and get on with it, or wait and let that medication metabolize a little bit and try again, in 30 minutes or something like that. That's a common, or some anesthesia providers will even try again immediately, but there's some reasons to be really cautious with that. So, yeah, we need some time for the spinal to set up and kind of declare the level of anesthetic it's going to provide before bringing the partner back.
Okay. And the needle is nothing like the epidural needle, right?
It's longer and very skinny. And so if you saw the needle, it's not a threatening looking needle except for its length, because it does need to go layers deeper into the back than the epidural needle. So you're looking for the subarachnoid space, which is pretty far in. So yes, sterile field, bee sting, areas numb. The spinal needle is introduced, and kind of the same deal as the epidural. Mom is paying attention to sensations down one leg or the other and communicating that back to the anesthetist or anesthesiologist. And the positioning is equally as important there. Moms have to curve their backs around the baby. So again, that's slumpy shoulders. It's the opposite of what a yogi would do, or probably the opposite of what teachers told most of us to do in class when we were young. Head tilted forward, shoulders rounded, and the lumbar spine as open and as soft as possible. So slumpy, slouchy posture, and likely you'll have an operating room nurse or someone in front of you so you can sort of rest on them a little bit. Maybe they'll give you a pillow to sort of ball yourself around. Anyway, that takes the same space and opens it up so that the procedure, it gets accomplished much faster that way. The spinal needle is introduced into the spinal space. And again, that's below the actual level of the spinal cord, to be clear. And it connects with the fluid that's always bathing the spinal cord, the cerebrospinal fluid. So medicine is injected into that fluid. That medicine lasts about 2 hours, depending on what you use. But the most common mixture is Marcaine or bupivacaine. And we often mix a little bit of morphine in that to offer some postoperative pain control. So, that medicine is injected in, and pretty immediately, everything comes out of the back, the drape comes down, and mom lays down on the bed. And then they do a uterine tilt to try and, get the compression off those major blood vessels. And then at that point, the rest of the monitors are going on, and mom is really paying attention to sensations. So nausea is really common at that point because the spinal anesthetic is so profound. It moves high very quickly and starts to anesthetize those parts of your nervous system that keep your blood pressure up and keep your heart rate up. So it's really common for the spinal to get high pretty quickly, and we're constantly monitoring that because we can tilt the bed a little bit and use gravity to invite the anesthetic further down. We can do a series of things to help with that, but nausea is really common at that point.
Now, the stuff that they give you a little shot to drink right before.
Oh, Bicitra. It's
Bicitra,
wretched.
It's awful.
It's awful.
And they warn you about it.
About that part, yeah.
It looks inviting. It looks like like an orange juice or something, but it tastes terrible. Like you can't sip it.
So,
what does that help with?
Yeah, exactly. A lot of people want to know what's that all about. It neutralizes the pH in your stomach. And so if you were to aspirate, vomit, and get any of your stomach contents into your trachea and into your airway, it's less damaging. And often that's why we're really meticulous about when did you eat last. If you ate recently, especially for the pregnant mom, we call them the NPO guidelines. They're even longer because gastric emptying is so much slower for the pregnant mom. So if you had a breakfast, 2 hours before, and this is an elective thing, we're not doing it. It's not worth the risk because if mom aspirates and gets contents into her lungs, it is pouring battery acid into the lungs. That's now you have to go to the ICU and you have to heal your lungs before you can meet your baby and take care of your baby. So what a nightmare, right? Mm-hmm. So Bicitra is one additional measure to neutralize any of the acid in your stomach as best as possible because people throw up all the time in the operating room. Now, if you're not...
Me.
Yeah. If you're not anesthetized, if your brain isn't anesthetized, it's okay because your gag and your cough mechanisms, those are all still intact. Those reflexes to protect your airway are still intact, and it's probably not a big deal. It's just uncomfortable, and please get it over with as quickly as possible. Likely, in addition to the Bicitra, you will have received a series of anti-nausea medications from the labor and delivery nurses. Typically, they do that stuff before coming back to the operating room, but yeah.
Okay. So after the C-section, the C-section itself is like, 15 minutes to get baby out and then another 30 to patch up?
Excuse me. That all depends. If you're a repeat C-section, there's a lot of scar tissue to navigate. Says the surgeons. I've never, again, this isn't totally my lane, but the surgeons will comment on the length of time it's taking because they're having to tease through different things. First time C-section or maybe second C-section, it's pretty quick. And when a surgeon is in a real hurry, it can happen very quickly. I've seen maybe 3 minutes before. That's
3 minutes?
That's probably the fastest to get baby out. And that was an emergent situation. Typically, I think the benchmark for the team that I work with, they're always aiming for 5 minutes. There are reasons they go beyond it, and sometimes they go a little faster than that. But 5 minutes to get baby out. So now, baby's out. The whole energy of the room is different now because baby's declaring their presence in this really cool way. And the teams are taking care of baby. So mom gets a little... often moms get a little stunned at this part because now baby's been delivered, but you're wanting to connect with your baby. They're taking care of baby, cleaning baby up, getting vital signs, doing all these things, and you're still sort of open. You're still on that OR table waiting. You, as a mom, will likely feel lots of pressure changes. So the spinal typically takes care of temperature and pain. It does not influence pressure much at all. So anytime they move your uterus around or as they're stitching it really tightly, that will trigger nausea, and it triggers these big groans that I see moms. I see a facial grimace. It's like, oh, okay, yes, they're stuffing your uterus back into the right spot, and all that tugging and pulling, there's really no reliable way to get rid of any of that. So all of that you still feel. And
that lovely massage after in recovery.
Right, that continues.
The massage, and I'm putting him in air quotes.
Right,
it's not a massage.
The fundal massage never looks comfortable. So yeah, mid C-section, baby's out. There's a connection with mom and the baby as best as they can manage that. Sometimes I see a lot of skin to skin. I see a lot of baby separated from mom for whatever reason, because maybe baby had some meconium that they're dealing with or whatever, so that post-delivery picture is a little different for each mom. So the suturing and all of that takes some time to do that perfectly. If there's if there's a source of bleeding that the surgeon doesn't see, but they'll see the blood, but they don't necessarily know where it's coming from, that takes time to sort out, reinforce that area for however they do that. So the sewing up can take a while. So I think my hospital books about an hour, 45 minutes to an hour for a C-section.
It's about here too.
Yeah, getting a baby out is the quick, easy part. After that, it feels forever. People are often asking me, even though it's only been 15 minutes, dude, when are we going to be done? How much longer? And then, they prompt the team with that question over and over because they're sick of it, and you want to move, and you're literally paralyzed from your diaphragm down. So,
which is a really trippy feeling.
To have an open abdomen, have a new baby, and not feel most of your body, that's
because they ask you before
a surreal experience.
Before they cut, like, hey, can you feel this? Feel what? She ready?
Yeah, that's the Alice test I was mentioning, and I often coach them: don't ask the mom, just do it. Mm-hmm. And because often moms, really nervous moms, will feel that pressure, and they'll give us a weird answer. It's like, oh, I felt that. And it's like, wait, what did you feel? I felt you doing a thing. Well, did you feel the pain? Well, I don't know. And so anyway, now it starts to
have nothing to compare it to.
Right.
Really.
It gets vague and weird, and now we have to decide, all right, let's do this again, because we got to make sure you don't feel the pain of this. Otherwise, we got to look at the other options. So, okay.
And recovery's 2 hours. So after everything is stitched up and she's ready to go into recovery, she'll be in there for an hour or two.
Different hospitals have different policies, but typically 2 hours. And they're looking for a few things. They want the anesthetic to wear off, the spinal, because the sooner mom is walking around, the better. Yeah. A lot of moms are like, please, I'm ready for a steak while they're still in the OR. Like, I want like a giant drink. I want whatever. I want a steak.
Well, they haven't eaten since like 9 o'clock the night before.
Right.
So they're probably
when they've followed the instructions, yes. And, often there's a delay. Like, it's this slow progression. Ice chips, let's see how that goes, and then work up from there. So some people are surprised by how long it takes to advance to a full diet.
And it's really not, you think you'll want the steak.
Right.
And you'll think you'll want this big meal.
You have the craving, yes.
But
your stomach's not ready for it.
Yeah.
So the nausea is so profound as soon as you introduce something, because the spinal manipulates peristalsis, and in some cases it speeds it up in this crazy way. In some cases it slows it down. So taking your time at that phase is really helpful. Otherwise, you're miserable with more nausea and more vomiting and all that.
I remember. Let's go back to the operating room for just a second, because I left something out. Delayed cord clamping. Mm-hmm. It's something that a lot of our clients do want. Sure. In a vaginal delivery, it's 30 seconds to a minute is the standard.
Okay.
And let's just say some moms want it to delay until it stops pulsating, or delay cord clamping for 3 minutes, 5 minutes. Do you often see that being a possibility in a C-section?
To some extent, yeah. I watched the surgeons. I watched them very carefully, because I know what the surgeon knows that the mom doesn't know is she's bleeding profusely. So the longer you wait, you've got a surgeon holding the baby, looking at the cord, trying to decide what's a reasonable amount of time to give mom what she's asking for, and also to keep mom safe. Or if baby for some reason isn't doing well, then maybe there's a rush to get the baby over to the pediatric team. And then cord clamping, in a delayed way doesn't make much sense. But the surgeon is watching the uterus continue to pull more and more blood. And it's a It's a bit of a dance. It is a bit of a dance. So I see surgeons delay cord clamping. Now, I'm not using a timer, so I don't really know how long they're waiting. But I anticipate they are trying to find that reasonable sweet spot. I want to give mom what she wants. And also, I don't want mom to need a blood transfusion. So, okay, now is good.
And most moms, if not all, I mean, all moms, I can safely say all moms, at the end of the day, they want to be healthy and they want their baby to be healthy.
Without a doubt.
So if they don't get the 3-minute delayed cord clamping, they get like a minute or a minute and a half, but it keeps them from having that blood transfusion. I think they're okay with it.
And often it's just the gesture of giving it a little bit of time, 5 or 10 minutes or until it stops pulsating. That's a luxurious thing.
Well, giving her something, because she most likely came into this situation, not wanting to sign up for surgery. Now, there are some people that do sign up for surgeries, and that's okay. Right. But in a lot of cases, it's an unplanned thing that turns into a planned thing.
Sure.
So being able to give her something,
some agency,
out of her birth plan is really nice.
Without a doubt.
Now, cutting the cord, do you see a lot of dads and partners cutting cords still?
Yep.
I mean, minus if it's not an emergency situation where they had to get them to the peds.
Right. Yeah, they leave along what looks like a trail of cord so that dad can go over to the bassinet area and cut the cord there.
And it's not, if you've never cut an umbilical cord before, it is not like the movies. It's not a simple cut. You really have to work through.
You're like cutting a rope, and it gives
hard.
you a respect for what the human body is creating to sustain baby and grow baby. It's
in
really
movies,
cool.
It's like snip, but in real life, it's and dads are always surprised by it. I have to really
dig into
this thing.
Right.
Cool. So we had the emergency C-section part 1 episode already, and we talked about everyone's role in the operating room. Mm-hmm. Is there anything different as far as people's role in a scheduled C-section, or is it the same people, same role?
Same people, same idea. If there is a known complication with baby, if they know baby is likely going to come out needing a lot of support, then you've got a big pediatric team. Or if there's some sort of known accreta or some sort of...
Which is serious.
Yeah, if there's some sort of nuance with the uterus and the placenta, then they'll have an additional surgeon available. Or if... Yeah. So based on mom's baseline and baby's baseline, that'll determine how many additional people come.
Okay. Jonas had a big team.
I bet he did.
It's funny how everything just really switches gears once the baby's born. It's all about mom for a long time, and then it's baby.
Well, it's baby, except anesthesia and surgeon, we stay focused on mom.
Yeah.
And we're taught all of these ethical dilemmas about baby's not doing well, but your responsibility as mom, what do you do? Do you leave mom to go take care of baby? And that's one of those philosophical things we spent a lot of time talking about in anesthesia training.
Yeah. Like if you're on the boat, who do you save, your wife or your mother?
Yeah. Well, and it often isn't that serious. It's often not either or in truth, because the spinal's doing well. Mom's been stable with it for a while. Your blood pressure is going to cycle every couple of minutes. So you're going to get your cues from across the room. But if an anesthesia provider steps away from mom and fully engages with baby and doesn't notice what's going on with mom, that is a very big deal. That may be the end of that person's career. So,
Yeah. Not something to play around with.
Not something to play around with. And maybe there's a point where that's what needs to happen. I have a colleague who did 2 C-sections at once. One anesthesia provider for 2 C-sections because baby was in distress. So not a colleague I currently work with. So
obviously,
anyway, this person still does anesthesia, but he was so clear that was his moral obligation to accept a certain amount of risk to protect baby, and he was willing to lose his license over it.
Wow. You guys are the MVPs.
Anyway, that's not common.
So all right. So we're back in recovery. I switched gears. I went out of the operating room. We're back in the operating room. Now we're back in recovery. Mom's going to be in there for an hour or 2 until she feels her legs. And then they typically switch her to a postpartum room at that point. Right. Recovery isn't a glamorous place. It's
Right.
typically a really small room or a room with drapes
Right.
surrounding a bed. I mean,
Right.
it's really just bare bones.
Right.
A monitor, the mom, the bed, and that's it.
Pretty simple. Yeah.
You're breastfeeding at this point if that's what you're choosing to do.
Right.
And trying to just basically recover. You're given medications post surgery. Can you talk about those medications and what they receive, or is that
Well, sure.
after the surgery?
I mean, I'm long gone. I'm into
Yeah,
my next thing at this point.
you're already in another C-section.
Right. Yeah. And a labor and delivery team would be awesome to address this. But the medications I know about, Pitocin, they continue to give Pitocin.
But it's not the same. I mean, it's the same Pitocin, but it's not what the heavy contractions, like painful Pitocin that you think of in an induction.
Right. It's the same medication given, and I actually don't know the dose that they're using, post-operative compared to the laboring dose where you're really trying to induce a lot of activity.
Different feeling.
Definitely
it's doing the same
different-
type
yeah,
of thing.
right.
But
Okay. Pitocin, more fluids, pain medications. There's often a strong intention to get some longer acting pain medications on board. One of them is a medication called Toradol. Often I give that in the operating room before we leave, as long as the bleeding hasn't been super significant. And that carries the pain control pretty well on its own.
gotcha.
Gosh, I don't know what else to give. I'm long gone.
This can be another episode. Then we can do this again. Now, before we wrap up,
Sure.
there are some things that can happen post surgery. After you get home, you might experience something, back pain.
Right.
Is there anything to kind of go over that the mom can possibly expect a day or two post surgery that maybe she doesn't know about right now?
Well, a lot of people are really concerned about, back pain for sure. That's a common one. A couple of people that I've interacted with have had chronic back pain. They thought it was a chronic back pain that evolved from their neuraxial. And when I say neuraxial, I mean epidural and spinal. And I don't know what that's about necessarily because it's not something I've seen in my practice, but I have heard case reports of people having back pain after getting an epidural or a spinal. One of the theories is that anesthetizing some of the muscles that help maintain your posture, when you anesthetize those so profoundly, you sort of trigger a short-term adjustment or the back pain that's associated just with such profound anesthesia and muscles that never relax kind of for the first time. I don't know how much validity there is to that, but I do have a friend who has chronic neuropathy down one of her legs after an epidural. This was back in the 80s, but she's lost muscle tone and in her right leg, and it's really influenced her life. But that's very rare, and especially that's why we don't do epidurals and spinals for people who are asleep. If you have a general anesthetic on board, we can't do it because we need that feedback. So when we're placing an epidural or spinal and I'm asking, do you feel anything down your left leg or your right leg? That's what I'm avoiding, essentially. I'm avoiding long-term complications. When you say, yep, I feel a thing on the left, great, that's my cue to move to the right. So that feedback piece helps prevent long-term complications. The spinal headache is probably the most significant thing that people encounter after an anesthetic. And it's usually young, healthy females who had an epidural that worked really, really well, like surprisingly well. It was kind of a spinal, is what we learned later. And that headache is incredible. I mean, it's the worst headache. People often associate that as much more painful than any of the pain with labor or delivery.
I never had that, thank goodness. But.
Yeah, that's probably the big one. Spinal headaches, from an anesthesia perspective. Some people have urinary retention after a spinal or an epidural, but that typically will have to resolve before discharge. People don't typically go home with that as an ongoing issue. So once you anesthetize some of those feedback mechanisms, in the urinary system, they've got to come back online before you can leave. That's probably the big deal, though. The spinal headache is, anesthesia, it comes on and it comes off pretty reliably. So
easy fix. Just go in the hospital and they can fix you right up.
Or, drink a lot of fluid, take some caffeine, drink your coffee. Ibuprofen. Those things address it most of the time. But there are a couple of different things you can do for a spinal headache. One is the epidural blood patch that I talked about. That's, in my mind, that's the big gun. That's for when the headache is really severe, and that's a very effective way to treat it. Another is called sphenopalatine block, I may not be saying that correctly. I've only done one of these in my life, but it's taking a long Q-tip and inserting it into the nose kind of as far back as it'll go, and dripping an anesthetic to go and anesthetize the base of...
I'll take the blood patch.
Yeah. Well, if you don't want a needle in your back...
I'll take a needle over something up my nose.
I hear you. I might too, but some people don't want the needle.
Yeah.
They'll be okay looking at a stick coming out of their nose. But apparently that's really effective too. I've only done it one time, and I did it with someone kind of coaching me every step of the way. It's not super common, but if you don't want to run the risk of another dural puncture, which is what you run the risk of with another epidural, all right, there is another option. So.
Well, cool. Well, this has been extremely helpful. Thank you again for being on. Hopefully you'll come back for some extra down the road.
Absolutely.
All righty. Well, we will see you soon.
All right. Lovely.
Bye.
Bye.
Thank you so much for listening, and please don't forget to subscribe and share this podcast with your friends. Seriously, it would make my day. For more information on Uptown Doula, please visit our website at www.uptowndoula.com. See you soon.